So I would like to thank you all for being here, and I'm really excited from the full room, because in sleep medicine lectures it's not always like that. And I'm very, very happy and honored to be chairing the lecture of Professor Silke, not only because she is the current president of the ERS, but also because she's a woman president, and also because she comes from the field of respiratory medicine. And I think that it is very, very important for all of us that we work in this field. So I'm sure that you all know her. She's a consultant in respiratory and sleep medicine at St. Vincent's University, and also she is a professor of respiratory medicine and sleep disorders in Dublin. And she has been worked along with all the other topics that she has worked with on the cardiovascular effects of sleep apnea. And I think that her lecture would be very, very exciting, because I know she is dedicated in this topic. Thank you, Silke.
Yeah, thank you so much, Athanassia, and really thanks to the organizers for allowing me to be here and to speak. It's, I mean, such a great honor and pleasure for me to be here. And you know, I did a little walk early on in Athens. I mean, you're probably about 20 degrees hotter than we are in Dublin, so what a city to be in. Okay, so in my talk I'm going to elaborate a bit on some translational aspects of the association of obstructive sleep apnea and cardiovascular diseases, which indeed is a very hot topic in our field. Am I able to work this? Yeah. These are my disclosures, none of them really relevant to this talk. So obstructive sleep apnea, as I'm sure many of you are just too well aware, is a condition which has really rapidly and dramatically evolved into a significant public health burden. And this is certainly on one hand due to the very high, steadily rising prevalence of the condition, but on the other hand, this is also in particularly due to the significant morbidity and mortality associated with sleep apnea. The latter has been firstly highlighted by these data here from the Sleep Heart Health study, a large population study from the US. This was published now 15 years ago, demonstrating worse mortality with increasing severity of obstructive sleep apnea, adjusted for multiple potential confounding factors. And cardiovascular diseases represent the principal physical morbidity and mortality of sleep apnea, and sleep apnea has been identified as a significant and independent risk factor for the development and control of now numerous cardiovascular diseases, including systemic arterial hypertension, myocardial infarction, atrial fibrillation and other arrhythmias, stroke or heart failure. Sleep apnea is now also increasingly recognized as a risk factor for metabolic disorders such as diabetes or insulin resistance, and there is even a potential risk for cancer. However, with all this knowledge, which is quite clear, we are still lacking really effective treatment strategies for cardiovascular diseases and obstructive sleep apnea, and particularly CPAP therapy, of course, the treatment of choice for the majority of our patients, and which is highly effective in improving symptoms such as daytime sleepiness and quality of life. It is not universally effective as a treatment strategy for cardiovascular complications. And this has particularly been put into questions by 3 recent large randomized controlled trials, which all failed to show a benefit of CPAP therapy in reduction of cardiovascular events. And these were all patients with established cardiovascular disease, so there were secondary prevention trials. I'll come back to that in a little while. So we are lacking effective treatment strategies, but to find those, we still need to understand better the exact pathophysiology underlying cardiovascular complications in sleep apnea. And although we have seen significant progress over the last few years, this process and the exact mechanisms still remain incompletely understood. Now this slide still in a very crude fashion summarizes our current understanding of the mechanisms, showing just the main pathways to be involved. Sleep apnea comprises various significant pathophysiological triggering factors for cardiovascular diseases, but certainly beside intrathoracic pressure swings, which has direct effects on cardiac output, recurrent arousals, which leads to sleep fragmentation, it is particularly in sleep apnea, so typical pattern of intermittent hypoxia, which plays a key role. This is a typical example of an intermittent hypoxia pattern in a patient with severe obstructive sleep apnea. I'm sure you're all well aware of it, but it's a pattern which is unique, characterized by these very frequent short cycles of rapid desaturation followed by rapid reoxygenation. So up and down, several hundred times a night, as in this severe case, a pattern which is profoundly different to the more chronic sustained hypoxia which we see in other chronic respiratory or cardiac conditions. And hence, not surprisingly, such a pattern will lead to very different and distinct pathophysiological and molecular consequences. Now, the pivotal role of intermittent hypoxia has been recently supported by large data from population or clinical studies showing that markers of intermittent hypoxia are better predictors of cardiovascular outcomes than markers which do not take the intermittent hypoxia into account, particularly the traditional severity marker, the apnea-hypopnea index, which is just literally indicating the frequency of breathing disturbances. Of particularly relevance in this regard is the recently described marker of hypoxic burden, which is defined as the sum of the severity of the individual desaturations, so the areas under the curve. So it's a more complete marker than what previous marker like the oxygen desaturation index or the mean oxygen saturation may describe. And here on the right, you see the index paper of this hypoxic burden marker from Ali Azabarzin and co-workers from Harvard, demonstrating in two different cohorts, the osteoporotic fractures in men study and the sleep heart health study, that the severity of hypoxic burden was a strong and significant predictor of cardiovascular mortality. And in case of the first, it was also a strong predictor of all-cause mortality. And importantly, these relationships were not detected when the hypoxic burden was replaced with the AHI. However, clinical studies are limited given the fact that obstructive sleep apnea is such a heterogeneous condition. There are so many potential confounding factors, and they influence our relationship in determining the direct contribution of intermittent hypoxia or other pathophysiological triggering factors to the exact disease processes. So most of our evidence which we have from the role of intermittent hypoxia has been derived from models of intermittent hypoxia. So cell culture, animal and human models, and they simply have the advantage that they allow us to study intermittent hypoxia in isolation. We can tightly control these events, both in duration and severity, and they can also provide us with genetic homogeneous population. So they overcome a lot of limitations which we would see in clinical populations. Of particular relevance in this regard is the rodent model of intermittent hypoxia, which is quite simple. So animals intermittently breathe nitrogen-enriched air to mimic hypoxic periods, and then air or oxygen to reproduce the reoxygenation events. And many studies using such model have shown that intermittent hypoxia leads to vascular disease. Now, a lot of these studies have varied in their protocols in terms of duration and severity, and to account for these potential differences, the Grenoble group of Jean-Louis Papin and others have recently provided us with a very detailed systematic review and meta-analysis, which is the last paper here, so published in the ERJ in 2022, comprising a total of 125 studies. And the analysis concluded reassuringly that indeed in a dose-dependent fashion. Intermittent hypoxia leads to vascular remodeling, so where you can see these breakdowns of the endothelial barrier in stream of inflammatory cells into the vessel wall. And when this was studied in atherosclerotic prone animals, apolipoprotein deficient mice in particular, then you see also in response to intermittent hypoxia an increased plaque burden in these mice. So intermittent hypoxia initiates and promotes the progression of atherosclerosis. And altogether, this is not too surprising, as the process of atherosclerosis really throughout all stages, but particularly at the initial phases, is a process of inflammation, characterized and contributed by numerous inflammatory cells. And intermittent hypoxia has been shown, and this is supported by ample evidence from various lines, is a potent trigger of pro-inflammatory pathway activation. And as we and others have extensively shown, intermittent hypoxia preferentially activates pro-inflammatory pathways, mainly mediated by the transcription factor, nuclear factor kappa B, over more adaptive hypoxia-responsive pathways, which would predominate in chronic sustained hypoxia. So, and as consequence of this imbalance towards this pro-inflammatory response, intermittent hypoxia leads to a low-grade pro-inflammatory systemic milieu, which then ultimately affects the vasculature, leads to vascular inflammation. And this has also been shown in patients with obstructive sleep apnea. Now, besides the activation of pro-inflammatory pathways, intermittent, so I just go back here. So one of the important questions in this regards has been in relation to the potential source organ of pro-inflammation in response to intermittent hypoxia. And one of the key organs which has been particularly come into focus over recent years has been the visceral adipose tissue. And this is very similar to the role of the visceral adipose tissue in obesity. So visceral adipose tissue per se is now known a very highly active endocrine organ. It participates in many physiological and pathophysiological processes. And in obesity, so where you have an excess of adipose tissue, there is a constant low-grade production of pro-inflammatory mediators, cytokines, and so on, which then contribute to a lot of adverse consequences, metabolic dysfunction, impaired immunity, and vascular damage, and so on. And one of the key mediators of these responses in obesity are the macrophages, which are contained in the stromal vascular fraction of the adipose tissue. So the stromal vascular fraction are all the cells which are not adipocytes. And as said, macrophages play a key role in mediating many responses. And in obesity, these macrophages undergo considerable morphologic and phenotypic changes. So whereby lean adipose tissue is characterized by an infiltration of macrophages from an anti-inflammatory, so-called M2 phenotype, which lead to the production of anti-inflammatory adipokines, adiponectin in particular. With increasing obesity, these macrophages polarize towards a pro-inflammatory M1 subtype. And these pro-inflammatory macrophages are primarily responsible for the production and secretion of a multitude of pro-inflammatory mediators, as listed here. A very typical morphological characteristic of dysfunctional obese adipose tissue are these so-called crown-like structures. Crown-like structures which are M1 macrophages surrounding necrotic adipocytes. And interestingly now, in intermittent hypoxia, we see exactly the same changes occurring as we see in obesity. So these are data which are from our laboratory in collaboration with the Grenoble group, but they have also been reproduced by others, where we looked at adipose tissue morphological and phenotypic characterization of macrophages in mice which were exposed to a standard protocol of intermittent hypoxia for 6 weeks or intermittent air as control condition. And we used lean and diet-induced obese mice. And in both of these mice, we saw that intermittent hypoxia increases the percentage of M1 macrophages. And importantly, these correlate significantly with the level of insulin resistance, so with metabolic dysfunction. We also saw an increase in these crown-like structures detected by F480 immunochemistry, which is a marker of macrophages. And you can see this was shown in lean mice and also in obese mice, although in the latter this did not reach statistical significance. But this is mainly due to the very high variability of adipose tissue in obesity. So intermittent hypoxia alone and amplified in the presence of obesity shifts healthy adipose tissue towards a dysfunctional adipose tissue. And as a net consequence, we see then increased inflammation, decreased metabolic control, and this is likely an important factor in metabolic dysfunction in obstructive sleep apnea. So besides activation of pro-inflammatory pathways, intermittent hypoxia is also well known to lead to hypertension. There is numerous lines from preclinical to clinical studies on this. Studies go back already to the early 90s, as here from Eugene Fletcher and co-worker, where he showed already that rats exposed to intermittent hypoxia experience an increase in blood pressure, which is persistent even after cessation of the stimulus. And it is known now that the sympathetic nervous system plays a key role in mediating this response. So intermittent hypoxia likely contributes to vascular disease and the process of atherosclerosis through 2 different mechanisms. So one are the direct effects on the vasculature. So as I said, to activation of pro-inflammatory pathways, probably also oxidative stress. This is not as well characterized in general. And indirectly through mediating hypertension, which of course is a well-known risk factor for atherosclerosis. So with the knowledge of same, how can we potentially act upon these responses and can mitigate these adverse effects? So what about CPAP therapy? So CPAP therapy, of course, if applied and titrated correctly, will eliminate intermittent hypoxia. It will take it out of the equation. But yet, as I said earlier, several randomized control trials failed to show benefit of CPAP therapy on cardiovascular events. Now, these studies had significant limitations. I'm not going to get into this in too much detail, but one of them was that there were all studies on secondary prevention. So all patients who had established cardiovascular disease, so patients who are rather at the end of this pathogenesis of atherosclerosis. However, there is increasing evidence that CPAP therapy may be particularly relevant for early cardiovascular disease, so for primary prevention. And in support of this hypothesis, CPAP therapy has been consistently shown to improve endothelial dysfunction. Endothelial dysfunction, which is an early and potentially reversible state in the process of atherosclerosis. And as shown here and summarized by 2 meta-analyses, there is CPAP therapy improves endothelial function. And importantly, this effect also exceeds to patients who are minimally symptomatic. Now, until very recently, we had very little ways of detecting early atherosclerosis, so beyond the functional state of endothelial dysfunctions in humans. But now modern imaging techniques have given us the opportunity to bridge this gap. And we recently performed this proof of concept, prospective, randomized, parallel trial, where we compared the effects of CPAP therapy to a GLP-1, so liraglutide-based weight loss regimen, or both in combination in patients with obstructive sleep apnea over a period of 24 weeks. And we utilized 18-FDG PET-CT scanning, which is a very highly sensitive method for detecting early vascular inflammation. And we also used CT coronary artery scanning with semi-automatic AI-enabled analysis of atherosclerotic plaque subtypes in this cohort. Now again, this was a proof of concept study, so we have small numbers. But despite these small numbers, really to our surprise, we saw a significant reduction in the level of vascular inflammation as detected by FDG PET-CT scanning with CPAP therapy. And this was also associated with an improvement in endothelial function and proportional increase in nocturnal oxygenation. We also saw a decrease, although this was not statistically significant, on the right, in the volume of low attenuation non-calcified plaque burden. Now, these low attenuation non-calcified plaques are of particular relevance. These are the lipid-laden plaques, which are much more likely to rupture. So they are the ones who are unstable and much greater predictors of cardiovascular events than stable calcified plaques. And of interest also was that we did not see any of those effects with liraglutide, although significant and expected weight loss was achieved. Now, I don't in any way want to dismiss the potential effects of GLP-1-based pharmacotherapy, particularly on the background of these recent results which were published from the SORMONT OSA trial in the New England Journal of Medicine very recently, which investigated the effects of the dual receptor agonist tirzepatide in patients with obstructive sleep apnea over 52 weeks. Now, tirzepatide leads to much greater weight loss than liraglutide, and this was also being seen in this study, and this was associated with a considerable reduction in apnea-hypopnea index, and there was also a reduction in high-sensitivity CRP level as marker of systemic inflammation, and also an improvement in blood pressure, and this was particularly seen in patients who were naive to CPAP therapy. So although these studies are really promising, indicating a potential role of weight loss in reducing vascular inflammation, however, we still don't know how this relates to really hard cardiovascular outcome, cardiovascular events, mortality, and so on. And we also still lack data of this treatment in real-world population. Real-world population which do not all have access to these drugs, where compliance, side effects play a much greater role. So we do need more data. So there is still a lot more to do to define effective treatment strategies for cardiovascular diseases in obstructive sleep apnea. And important such treatment strategies need to be holistic. They need to take the real whole complexity of obstructive sleep apnea into account. I didn't really get a chance to get into it in great detail, but although intermittent hypoxia is a dominant triggering factor for cardiovascular disease processes, is for sure not the only one. And this complex interaction with other pathophysiological triggers, as shown here, and the relative contributions of all these triggering factors is still not very well explored. Furthermore, there is a lot of modifying factors in populations of patients with obstructive sleep apnea, and they, of course, will change the individual susceptibility for cardiovascular disease processes. So treatment strategies not only need to be holistic, they need to be personalized, and this is something which is important for the future to determine this in greater detail. So, to summarize, intermittent hypoxia is the key pathophysiological driver of vascular disease and obstructive sleep apnea, and there's lots of data to support that. CPAP therapy improves endothelial function and may have a positive impact in primary prevention. And this is important to note before we dismiss the potential effects of CPAP therapy on vascular diseases. And as mentioned at the end, management of vascular disease in obstructive sleep apnea requires a holistic approach, and personalized treatment strategies are urgently warranted. I thank you for your attention, and I'm happy to take any questions.
Thank you, Silke, for this very interesting lecture. And any comments?
Yes. You said about adipose tissue. We have two types of adipose tissue: brown adipose tissue and white adipose tissue. Brown adipose tissue is beneficial. Mm-hmm. How can we check which adipose tissue we have? The simplest method is by CT. If you perform a CT on the lipoid tissue of the interatrial septum and you measure Haswell units, if this brown, it's negative. If it's white adipose tissue, it's positive. So it's a simple way to differentiate this.
Yeah, absolutely. Now, brown adipose tissue in humans is contained in just certain fractions, which we didn't look at. I should mention that what we looked at is purely on white adipose tissue. But you're absolutely right, and we still don't really know how intermittent hypoxia potentially affects brown adipose tissue. There are controversial data seeing that intermittent hypoxia has led to an increase in brown adipose tissue. I'm a bit suspicious that this is not the true effects. It's more the effect of weight loss, which we often see in intermittent hypoxia-affected animals. We certainly didn't reproduce these results. But it's an important point. You're absolutely right.
Thank you, Silke, for this excellent presentation, as always. And I do agree that we need randomized control trials in collaboration with real-world data, because are not opposite, they get be synergetic with cardiovascular outcomes. A little bit, not provocative, but a question related to mild intermittent hypoxia. Is it worth it to reverse it always, or we need to sub-classify the patients and see their stratification in this patient population related to cardiovascular risk? Thank you.
Yeah, thank you, Sophia. I mean, absolutely. So there is data, and we have also shown this in preclinical studies, that mild intermittent hypoxia is beneficial, and that makes complete sense. No? I mean, you get kind of a preconditioning event. You get adaptive responses that can prevent potential actions which are derived from more severe intermittent hypoxia at a later stage. The problem, of course, we have in clinical practice is that we don't know the threshold. We don't know what intermittent hypoxia is acceptable and what not. I mean, we know that the AHI is an absolutely useless marker, but we also, I think, are lost in our search for a marker per se, because there's so many factors which we cannot account for. The duration of intermittent hypoxia, like how long have patients had obstructive sleep apnea before they are diagnosed and treated, and this will obviously have implications for detecting a beneficial effect of mild sleep apnea. I mean, there is, from what we have in clinical populations, certainly reasonable belief that milder forms of sleep apnea without giving an exact threshold is probably not harmful in terms of cardiovascular effects. But it's in an individual decision-making, CPAP or not, always hard to give clear advice.
Thank you for your presence and your excellent lecture. Dr. Dervas, pulmonologist, you showed us the adipose tissue transformation and energization, activation based on the intermittent hypoxia. There is a theory about the multi-organ crosstalk that contains the very intestine, the cardiovascular system, the lung, and the kidney. What is your opinion on the latest data about this?
Yeah, unfortunately, we have very little studies who have taken a bit more complex view in this regards. I mean, certainly in terms of the intestine and the adipose tissue, there is a good bit of interaction. I mean, we know about the microbiome and so on, and intermittent hypoxia adversely affecting the microbiome, and this will have impact on adipose tissue, and this has also been shown in some single studies. We do need more data on this, for sure.
Thank you very much. It's a great honor to be here in Greece. I wanted to ask you your opinion about something not provocative, but what about this systematic inflammation regarding the intermittent hypoxia in OSA? What about an alternative treatment for patients with OSA? Not everyone, some groups, maybe young or maybe those who can have a benefit from this kind of biologic agents.
Yeah, great question, and I wish I could answer that to you. I mean, we have data from animals which showed that if you use aspirin, or the aspirin animal-treated mice had a decrease in their vascular disease in comparison to animals on placebo. So there is potential effect of anti-inflammatory effects. In humans, it's still very unexplored. I mean, with aspirin, of course, we have the dilemma now that it's not really clear, and even in primary prevention per se, what the role of aspirin is. Statins is probably a really interesting approach, because statins has not just the lipid-lowering effects, it's the anti-inflammatory effects. But so far, the data which we have in humans, also patients with sleep apnea, are still controversial and way too small that we can take more conclusion of it. I suppose the problem which we have always in the field of sleep apnea with clinical studies is that no one really has the guts to do these studies, and the ethical consideration. If you want to do primary prevention trials, you need years of study duration, you need lots of patients, you're withholding CPAP therapy, which for many patients is obviously so beneficial in terms of their symptoms. So it's very hard to answer that, but it's a very important and totally unexplored approach.
Thank you. Thank you, Silke. Thank you all. We have no time. We have to go to the next lecture.